Hey everybody, welcome back to the Fitness Athlete Podcast. We are joined by our very own Dr. Madison Lynn, our newest addition to the Fitness Athlete team. She joined us last year, so you can catch her in our Level 1 online course and also out on the road on our live course. So Madison is down in Oklahoma. She's a physical therapist and she also has her PhD. So we're super excited to have her on our team. And today, Madison and I want to talk about a case study that we did a year ago now on a individual who is a CrossFit athlete and also a aeromedevac flight nurse. So she does trauma flight surgical nursing, and talk about her case. I would be remiss to mention that Madison and I are both a little bit jaded about this case because we submitted it to present at CSM next year and we were denied. So we want to share this case with you and also kind of extrapolate and talk about the bigger picture clinical pearls that can be pulled, we think, from a case like this. So our patient last year was a member of the gym next door to our clinic in Fenton, Michigan, and Madison was with me as my student. And this is a member of the gym who has been doing CrossFit for the better part of a decade, has a very physically demanding job. As I mentioned, she is a surgical trauma nurse, and she's the person that lands in the helicopter when you're really in trouble. So she had a traumatic injury to her rotator cuff. She did try some physical therapy, saw some benefit, but not the benefit she needed to not only continue to see performance gains in the gym, but also be able to do her job. And so elected to have a rotator cuff repair surgery. And so she came to us and she had a challenge for us. She said, hey, I want to set up my rehab with you all after my surgery. She was going to do her surgery over the holidays and start rehab after the holidays. And she said, caveat, my surgeon has given me a 6-month post-op protocol, but I only get 10 weeks off of work. How far do you think I can get with PT in 10 weeks? Do you actually think I'll be ready to go back to the gym? And do you think I'll be ready to go back to work? And of course, we love a good challenge here at Ice Physio. So we said absolutely. So the patient's name is Jen. She's shared all of her information with us. She's obviously volunteered her information to be a case study. We also have this pending with JOSPT. So we're fine to share her name. Delightful lady, hard worker in the gym. Might surprise some people that she is, I don't want to give her exact age, but she's somewhere over the age of 40 and somewhere under the age of 60, which might catch some people off guard, seeing someone that they might consider old, looking to get back to things like kipping pull-ups and toes to bar and handstand push-ups and cleans and jerks and snatches and all the wonderful stuff that we do in CrossFit. So she came to see us and we started working with her twice a week. And across the span of about 8 weeks, we had 15 visits with her. So Madison, what kind of stuck out to you as she began her plan of care with us?
I think one of the most exciting things about working with Jen was her willingness to go all in to a style of rehab that might have been unfamiliar to her in the beginning, particularly if you think about someone coming from, hey, I tried some PT, it was more old school PT. Her idea of what rehab might look like across the course of that 10 weeks before she went back to work, I think was a little bit different than what we had presented her with. Like, hey, this is what we want to try, this is how we want to approach this. And anytime you're trying something new and different, particularly when it doesn't mesh with experiences that you've had previously, that can be kind of scary and kind of daunting. But she was more than willing to let us kind of take the reins and, more than anything, let her symptoms guide how we wanted to approach her course of care instead of us being locked into the 6-month protocol that her surgeon had originally put out there.
And I think, too, a great example of someone who is an advocate for herself of, I have to go back to work.
Absolutely.
So I really don't care what the surgeon says about what I should or should not be doing. No matter what happens with my surgery and no matter what happens with you all in rehab, I have to be back at work in 10 weeks or, she has a very long-term career in this position that she does not want to give up because she's not able to return to work. And so for her saying, I want to get as much out of this as I can is maybe a little bit different than what we're used to hearing when people come in to see us for rehab. Oftentimes you might hear, I'm here because my doctor said I have to come here, or I'm here because I have to do so much more PT before I can get my next pain injection or get the MRI or somehow move through the medical complex. This is a person who's coming to us with a very exact fixed goal in mind, which I personally find relieving to know where is our endpoint.
Yeah.
We have to do as much as we can to help this lady in 10 weeks because, as many of you who work with other healthcare providers know, especially nurses, schedules are not the best. This is a person saying, in 10 weeks, I won't be able to come to PT again. I might be able to come maybe once a month on my day off, but I have 10 weeks to be here as much as I can, and then that's pretty much it.
Her understanding of the medical complex, I think, was also helpful. She had a very, very good idea going in that she looked different than a lot of the people that are going in for rotator cuff surgery. So to be handed a sheet of protocols that is the same for her as it is for Jerry, who is 68 years old and hasn't done anything physically active since his high school gym class, like her understanding that the same set of protocols for those two very, very different people doesn't necessarily make sense was really, really helpful in getting that initial buy-in. She had a goal. She also understood, hey, I might not be the person that these protocols were really intended for as well.
And I'm so glad you mentioned that she looks different than most patients, because that's something we talk about in our level 1 course. If you haven't taken our level 1 course, it's a case-based course. We give you a case around a common clinical pattern in the fitness athlete. We talk you through subjective and objective findings that you'll see in the clinic. We talked through from high irritability to low irritability, what exercises and manual therapy treatments. And then we also have folks program a rehab programming for that person's case. But what we start every week with is what you're not going to see in these case studies is people here 3 to 5 times a week for 6 to 12 months. Because when we're working with fitness athletes, someone like Jen, who's been doing CrossFit for over a decade, that is overall a very healthy, robust person who has overall healthy tissues. If she didn't bump into this one specific thing with her shoulder, big picture, you would say this is probably one of the healthiest people I've ever seen. And so what's common is that these people come in even after surgery, baseline stronger, pain usually lower, strength, range of motion better. And we also see them just get better faster because overall their cardiometabolic health is so much better. So to me, this case taught me 2 different things. It taught me that even though I think I'm more on the aggressive side of rehab management, there was still another gear to find.
Yeah.
Not that we're trying to break this lady, but as long as her symptoms are responding how we're comfortable with and how she's comfortable with, we're going to keep the pedal down as much as we can. And so for me, it just kind of reinforced a growing bias that I have against surgical protocols, that they are designed for really no one. They're designed for a hypothetical person that doesn't really exist. It's a very generic, not to bash on them too much, but if you dig into some of the protocols, what you find is that they're not based on anything. There are no citations. And even if you have a good relationship with the surgeon who wrote it, if you ask them, what they will often tell you is they found it on another surgeon's website and just put their name on it. And then that became their surgical protocol. And so they're really generically designed, and they don't account for an anomalous person like Jen to come along who already is, presenting if she's 6 to 8 weeks along. She already has 150 degrees of flexion and abduction. She has a 1 out of 10 pain. Her strength is not where we typically see it post-op, where we have a little bit of temporary weakness. And she just doesn't fit into that protocol box. And this is not to say, if you're out there listening, ignore every protocol you ever see, but also don't ignore the person in front of you. Don't hold that person to that arbitrary piece of paper, especially if it is arbitrary. If the person in front of you is ahead of protocol, it's awesome that somebody is healing faster than intended. That should be celebrated. We shouldn't arbitrarily slow that person down just to make them look like this fake person on that sheet of paper.
I think it's important to recognize too that you can respect tissue healing times, or what we understand about tissue healing times from a pathophysiological perspective. while also understanding that the way that we create changes in tissue, the way that we build more resilient tissue is by loading the tissue. So it's so interesting to me how we sometimes get these protocols that immobilize people for long stretches of time when it's directly counterintuitive with what we understand, like Wolff's Law, Davis Law, where we're trying to create more resilient tissue by providing some sort of stress to that tissue. And of course, we have to, again, meet the patient where they're at and respect tissue healing timelines. But at the same time, if we are overly conservative, that's where you end up with these folks that are coming in and they're like, hey, I have absolutely no range of motion. And I'm like, yeah, you hung out like you had a chicken wing for 8 weeks, right? Of course you don't have any range of motion. And like far and above what my experience has been so far, and I'm sure that this echoes yours, is that the people that are able to stay within a guideline of what is acceptable as far as like discomfort and pain and move as much as possible, those are far and above the people that see progress more quickly.
And I'm glad you brought that up as well, because what's really cool about this case is that Jen came in with the expectation of us that at baseline, we would help her stay in the gym. So she had only missed a couple days in the gym before and after the surgery. She'd really only missed about a week in the gym. And it was her expectation that we, not only would we help her specifically with the injury, but globally help her modify around it and stay in the gym. So she was often coming to PT before or after CrossFit class next door and was able to stay in the gym and even begin to integrate some of the PT stuff into class. And it really kind of became, how quickly can we get her back to CrossFit? Beginning to show her things like landmine presses when she saw overhead lifting. I just looked at the treatment notes right before you and I hopped on here and saw that at 4 weeks we had her doing eccentric pull-ups. So she was working just the lowering of the strict pull-up. So she was already hanging on a pull-up bar by 4 weeks, which I think, again, might shock some people listening, but respecting her symptoms, never once did she have a significant flare-up. Never once were we worried about tissue integrity as far as post-op healing went. And she progressed as well as I think either of us could have expected. And she was able to do the open last year, modified and scaled, but she did one RX wall walk, I remember, and she was right in the middle of her plan of care, 5 or 6 weeks in the plan of care. And so able to participate in the open, able to go to CrossFit class whenever she wanted with our modifications. And I think that goes a long way too, as you mentioned, of keeping your heart rate up, continuing to load all of the tissues around the area goes a long way into facilitating a much quicker recovery. And so the final thing I took away from this case is just that this kind of care shouldn't be reserved for people who are already fit. Of understanding that if these principles apply to a person who's already doing it, it's really only a limitation on our own creativity, that we cannot use this stuff for, I hate to use the word regular person, quote unquote, regular person, but that the same principles apply. We should be loading these people early and often within their symptom tolerance. We should be checking on their symptoms between visits and, of course, at every visit. And if they're not experiencing a significant setback, we should really get out of their way. And we should incorporate not only higher intensity resistance training, but also cardiovascular exercise. Even if, hey, you can't use your arms, let's use your legs. You can't use your legs, let's use your arms. Let's get your heart rate up. We know that goes a long way to clear inflammation and also release pain-killing chemicals that help transition people off painkillers. I think, again, looking back at my notes right before we met here, of seeing that she was off her opioid-based medication in just a couple of days and not taking ibuprofen or anything non-opioid based. She just didn't need painkillers because we were able to get her back in the gym so quickly. And I think that's where we'd like to see every person end up, no matter if they're coming from CrossFit or coming from nothing when they come into the clinic.
Yeah. And I mean, I remember that first visit so vividly. She comes in and had maybe 4 or 5 days post-op. And she's like, yeah, I've been on a bike a couple times already. Like, she was already getting some blood flow to tissues that weren't going to make any sort of impact on her shoulder, right? But from a pain relief perspective, she was already doing herself some favors before she ever came to see us. And if we talk about this so much, and as a company, as a division, If we can allow folks that are coming in to see us to use the gym to manage symptoms instead of losing the gym, their overall health and the integrity of the tissue is just better. Why would we want to take somebody who already has a really good baseline level of fitness and allow them to slide back on that scale toward deconditioning, which just makes overall healing a little bit harder? I think that probably is the thing that has stood out to me the most when I'm applying the things that I learned from Jen to other cases. Is if I can take somebody wherever they're at, right? It doesn't matter whether I've got a Jen in front of me who's already incredibly fit, or I have somebody who's coming to me who perhaps they're, maybe they're generally active, but their level of fitness isn't quite the same. It's not necessarily going to change a significant degree of how I'm approaching that patient. I'm taking into account where their symptoms are at. I'm taking into account what their baseline level of fitness is, and I'm trying to challenge the tissues from there. If I can meet someone where they're at, and I can make sure that I'm dosing appropriately as far as exercise goes to actually make it challenging, then they're going to be moving in the direction that I want them to move. And I think that if we can utilize that, right, that symptom behavior model that we talk about so frequently, instead of a standard protocol that doesn't necessarily take into account where that person is at, for better or worse, right? Whether their fitness is less than the protocol might indicate, or their fitness is more. I don't care what the protocol says. I care what the person in front of me is capable of on that day when they sit in front of me in the office. And dosing, loading, challenging them wherever they're at is ultimately, across the course of our plan of care, what's going to make a greater difference for that individual. Definitely made a greater difference for Jen than if we just stuck to a protocol that doesn't really fit for her.
I think we often overcomplicate whether someone is coming in CDS onset or post-op. I think we overcomplicate what we need to do with them.
Absolutely.
I think it can be as simple as this person either needs help restoring local capacity, or they need help increasing their global capacity, or working global capacity because, at least temporarily, because they just had surgery or their irritability is very high, we can't target local tissue capacity right now. But if we pull the global capacity lever, we can get there a lot faster. And as we restore that local tissue capacity, that rotator cuff strength or that low back strength or whatever, it allows that person to further enhance their global capacity, which just makes them a healthier person who's less likely to need medical attention in the future. And I think we often overcomplicate our plans of care and try to address too many, call them faults or whatever, versus just reducing somebody's pain however we can, and then getting them moving, whether it's in a local area or getting their heart rate up. So I think we've done a good job of poo-pooing surgical protocols and advocating to maybe pushing people a little bit more aggressively. Madison, is there a time where you would be hesitant to apply this style of care to somebody? Or if you did, what would you be looking for to maybe pull back? Like where are the buoys at? Where do you want to stay safe at?
Yeah, I think that's a really fair question. In general, if I'm not worried about it, I think the one thing that comes to mind is if we've anchored into bone, if we're trying to heal broken bone. Like, bone integrity is one that I'm less likely to play around with those buoys as much, because we have a pretty clear idea of like, hey, it takes this amount of time for us to start to see closure of those types of injuries. But for the most part, I'm still going to meet the patient where they're at, right? Like the basic principles of loading, the basic principles of increasing the resiliency of a tissue, whether it's soft tissue or whether it's bone, don't change, right? The idea is that if we can apply some stress to those areas, that we're going to get growth and increases in resilience along the areas that we're applying stress. So I'm always meeting the patient where they're at. I think the occasions where I'm like, we might have to pull back a little bit is less about what's happening with the tissue and sometimes more about where the patient is at psychologically. So I will occasionally have those individuals that are coming to me that are really, really scared to move. And so the last thing that I want to do for that person, I think back pain is such an easy example. If I've got somebody that, is either, post-op back surgery or who's coming in with like a really flared up back injury of some type, and they're really, really kinesiophobic, like that idea of moving, you can tell, is really challenging for them, the last thing that I'm going to do is going to be like, barbell deadlift today, let's go, right? And it's not necessarily because I don't think that that patient could handle that, because I definitely have people on occasion that are sitting in front of me that I'm like, this is a person who could be doing exercises that are a little bit more challenging. But from a brain capacity, maybe we're not there yet. And so trying to find a healthy medium between not lowballing someone so much that we are inadvertently underdosing because they won't, like, quote unquote let us. Like, we Mitch and I did a course recently together, a live course, and one of the comments that we got from someone was like, I feel like across the course of care, we'll have 8 weeks with this person, and by the time that I've got them bought in to heavier loading into movement, like, their course of care is over and I'm sending them out the door. And so part of the onus on us as PTs is to get that buy-in a little bit earlier. So how do we challenge somebody? How do we put somebody slightly beyond their comfort zone, but not so beyond their comfort zone that they're never going to come back and see you again, right? And I wish there were a magic formula for how to do that. I don't know that there really is, other than we have to do a really good job of communicating with our patients that we believe that they're capable of more, that we believe that movement is safe for them. And we have to be absolute experts in loading, dosing, managing perceived exertion across the course of sessions with the people that are in front of us. So we have a good idea of when it's quote unquote safe, right? To say, you can do a little bit more. I know you can do a little bit.
I personally love, especially for that person. So I like to call that psychological irritability.
Yep.
Even though that person's physical irritability might tell us green light, load this person up. I think sometimes too, that even comes from just a fear of getting in trouble with the surgeon, as if they work for the surgeon instead of the other way around. They don't want the surgeon to be upset at them, or, if we botch this, the surgeon said he's, not going to work with me again. And then I'm really in trouble. And so I often will start the question, even the first visit, if I'm detecting a little bit of that hesitance of like, what do you have to do every day? And so someone who comes in and says, I can't do that because the surgeon said I can't reach my arm behind my back. I'm saying, well, how'd you put your bra on today? I said, well, I have to do that. So I had to do that. I had to bend over and put my shoes on. I had to pick up my kid. And I say, okay, well, those are things you have to do every day. We may not get you to the CrossFit games in your plan of care here at PT, but I know the stuff I'm going to have you do is going to get you back to doing those things that you have to do in a more comfortable manner, and also in a way that hopefully we don't see you back in the door for the same exact problem in the future. And I think if we can relate to those baseline functional things, the things that maybe are more relevant to the patient than us, because we don't have to deal with those problems because we're not the patient, but are very relevant to them, where they may have the opposite frame of mind of they don't care as much about doing kettlebell swings and riding the assault bike because that's not their daily life. I think if we can meet them where they're at, and like you said, get that initial buy-in, it becomes much easier to say, hey, you picked up that 40-pound kettlebell, that's the bag of dog food you have to bring in. We did that a week ago, you didn't have any pain, let's go heavier. Why? Because it'll make that bag of dog food feel better. It'll be that range of motion for taking your shirt on and off feel a lot smoother. And I think that buy-in can start as soon as the initial evaluation, if we're aware of how the patient is feeling and responding, and also able to connect with them about, what do you actually care about? Let's start there, and then we can layer in the fitness and conditioning later on.
Yep. I often will have, it depends again on the person that's sitting in front of me, but that conversation very early on, hey, that protocol that you were given, everybody gets that protocol. And so that recognition for people is sometimes really powerful, even for my folks who, they might not be in the top quarter of their gym that they're working out in, but they're still doing things on a regular basis. And most of the folks that are coming to see us that are participating regularly in CrossFit or in High Rocks or in some sort of functional fitness type of exercise, they understand that they might not be a games athlete, they might not even be a quarters athlete, but they also know that if they walk into a middle of a Walmart in small town America, they're probably going to look a lot different than the vast majority of the people in that space, right? So connecting that dot for them, hey, this protocol, not written for you, right? That often helps people feel a little bit more comfortable in, okay, I can probably push a little bit further than this, right? Like if their understanding is that those types of guidelines are for the person that the heaviest thing that they ever lift is their jug of milk off the top shelf, they become very, very comfortable with the idea that, oh, okay, I can probably push a little bit more because I'm lifting more than a jug of milk on a regular basis.
I think too, and this might seem contrarian for some people, to challenge the belief around the intention of the protocol, which
Mm-hmm.
is to have that conversation with people if they have questions about, well, I read that sheet of paper and it says I'm not supposed to be doing that, of saying, listen, you may not know how the medical system works, but your surgeon got a pool of money to do your surgery. Anytime you have to go back for future care, it comes out of that pool of money. From a profit standpoint, your surgeon doesn't want to see you again. And so very often these protocols are overly conservative to keep you at home, if only through the window of time that pool of money becomes permanent and
Yeah.
they're not cutting into their profit to see you again for a revision or something like that. Which is not to say the protocol doesn't have any value, but it's often overly safe. A lot like
Mm-hmm.
in pharmacology with lethal doses of half of the lethal dose is you're nowhere close, just taking a small amount of it, but it's designed to be so far away from danger that in this instance, I think can be harmful to people because it's
Yeah.
keeping them from progressing at a rate that accommodates what their
Yeah.
body's actually capable of.
Yeah. I had a patient who he had a very similar situation to Jen. He'd had a traumatic tear and he was a firefighter. And when he'd gone in to city medical, which is kind of crazy to me because when you think about the demands of a firefighter, like they've got a lot of overhead lifting and motion that's required. And so the initial that doctor that he went into, he asked, hey, I'm a little bit concerned post-op, like am I gonna get full range of motion back where I can get my bicep past my ear a little bit? And the surgeon was like, well, why would you need to do that? It's like if you were not in a space in a gym living a lifestyle that requires, like there are a lot of people that can probably go a big portion of their adult life without having to be here, right? Without requiring the level of mobility overhead that somebody who's going to do a snatch is going to need. But he needed that. Not only did he need it for his job, right? I would like anybody who's serving in a role like a firefighter to have full range of motion of their shoulder. But he also wanted to be able to snatch again. And so there's often a disconnect between the people that are writing these protocols and understanding where somebody eventually wants to get as far as range of motion. If the idea of the person who's writing that protocol is, they're not really going to need to get 180 back, right? Most people don't need that. We've got this huge chunk of the population that we are not putting in a good position to actually restore full range of motion if we're having them stuck here in that guarded position for 6, 8, 12 weeks.
And that just creates a future problem. That creates a future stiff shoulder
1000%.
patient where their active is equal to their passive. And when they go beyond that, they usually experience some sort of discomfort or pain.
Yeah, tissue is all the way locked down, so their primary objective of protecting their surgery has been accomplished, but then you have somebody again down the line who's now experiencing another whole set of issues that they didn't anticipate.
Never underestimate the power of the medical system to make you worse. Tim Flynn, I love that. Okay, Madison, thank you for joining us on the first episode. Any closing thoughts before we wrap up here?
I think if I had to sum up in impressions of Jen's case and what I would want people to take from this conversation is, as always, whether it's a patient who's post-op, whether it's a patient who's coming to you with just shoulder pain from CrossFit, we shouldn't be chasing a very, very specific set of protocols. We should be trying to adjust our approach to the patient in front of us. Symptom behavior model rules all.
And I think too, my final thought would be not only what we think the patient needs to do, but respect what the patient wants to do
1000%.
in the gym, at work, whatever. Match your plan of care to their actual goals. And as you mentioned earlier, I think that will get you to the buy-in space you want a lot sooner so that you have weeks or months to layer in that really heavy duty strength and conditioning.
Absolutely.
So you won't see this case at CSM next year. You will see us. I says you'll have a booth there, but we won't be talking about this case, but you will hopefully see it in JOSPT sometime soon. So thank you for joining us on the Fitness Athlete Podcast, and we'll catch you all next time.